About our objectives for this lecture. There's a lot of statistics in this lecture. I'm not a split hairs kind of person. Understand that sometimes males are more predominant than females, and that kind of stuff, but I'm not gonna, have my answer choices be 15.8%, 15.7%, 15.6%. That's not me, and that's not gonna do anything to get you guys past the board, so it's not that important. I simply give you that information to support, just help you understand the prevalence in a lot of things, okay? So basically, we'll just be, here's the objectives, you can read those on your own. All right, let's just start off with a bright, sunny, first thing in the morning kind of child maltreatment, okay? This is something, it was really kind of difficult to write this too, because a lot of these lectures, it's like what's going on with our Congress these days. Congress has, they're doing the sexual harassment training. Well, does anybody but me think it should be the anti-sexual harassment training? Not maybe how to do it, but how to not do it maybe? So, a lot of times you find child maltreatment spoken about in a way of how to do it. So I tried to basically very much avoid that tactic. So basically, physical abuse is an act inflicted on a child or a youth by a parent or caregiver resulting in mucocutaneous, musculoskeletal, visceral, or intracranial injury and or death. Although a medical diagnosis, physical abuse is also defined legally in state statutes. And it's 9 per 1,000 children a year. To me, that's just staggering in our society. Crosses socioeconomic lines, crosses racial lines, crosses ethnicity lines. There's no stereotypical child abuser. Kids can present in such a way. Some kids are at greater risk than others, unfortunately, if they're a difficult child. If there's a history of the parents were abused as a child, their children are at greater risk for physical abuse. If there's a history of parental substance abuse, or if there's a history of mental illness in the parent's part. So the maltreatment involved physical maltreatment, sexual maltreatment, emotional maltreatment, and abuse and neglect maltreatment are the 4 major categories. If you're in a situation and you think, I don't know, is this okay? What's going on here? If the history doesn't match the presentation of the injury, then that's a point to consider that it might have been a situation of maltreatment. We use an EHR system down in Duncan ER. It's called Meditech. And if I choose the pediatric trauma form, which is a template, there's a question on there that I have to check. Is this injury suspicious for maltreatment? Every single time, it just puts that right there. It's like the 4th or 5th thing on the EHR. And I think that's awesome because it just kind of makes you start thinking that way. If you've got a child in your practice that's well known to you, and you know this kid, and suddenly they start having changes in their personality, and you'll get to where, if you go into peds and you stay in peds very long, you'll get to where you'll know your kids' personalities, So that's a situation where you might consider emotional abuse, but it might not be from a caregiver. It might be this kid's just getting bullied at school. That is a form of emotional child maltreatment. You've got inappropriate sexualized play. Kids are all going to play doctor. They're all going to touch themselves, but if it's inappropriate, excessive, or not an appropriate age, any 18-month-old boy, you take their diaper off, they're going to find themselves, right? But, if it's excessive, then that might make you think, I wonder if something weird's going on here. Also, kids with sexual abuse will display sleep disturbances, appetite changes, enuresis, and encopresis. All right. Any questions so far? Okay. Oklahoma is a mandatory reporter state. We have an obligation. If you suspect child abuse or mistreatment, maltreatment, you are obligated to report with no fear of retaliation, okay? Another thing to remember is if you suspect sexual abuse, don't ever try to do an exam yourself. There's, at Children's Hospital, there's a team of people that can do the exam and the interview. It's all recorded, the kid only has to go through it once. These people are experts. Please don't cause more trauma to this child by trying to do anything yourself. 271 KIDS, that's the main number for children's. So that's an easy one to remember. You suspect anything that you want, to talk to an expert about, that's the number you're gonna call. And then we have a not so easy number to remember, 522-3511, but that's the abuse and neglect hotline for the state of Oklahoma. And we are, like I said, obligatory reporters. I had a situation when I worked the ER down in Purcell, and let's see, let me think exactly what it was. But this mom was well known to DHS. She had suspicious reports before. She comes in bringing her older child to be seen for like a sore throat or something. Well, the kid had burn marks on his arm that looked kind of old. And then she had a younger kid with her, and he had visible marks on his arm, or her arm, I don't even remember, that looked kind of newer. So my nurse also noticed it, so it wasn't just me. So we decided we would, report. Well, this mom had been reported so many times that what they did was DHS asked us to hold the kid hold the mom in the ER, find a reason to keep him in the ER, which really isn't that hard to do, because everything takes forever in the ER. And they went and got her other 3 kids, picked them up from school and took them into protective custody, and then came and got those kids from the ER. And unfortunately, I guess it's kind of obvious that I called, but the social worker said, oh yeah, it was the ER, it was the PA in the ER that called us, But here's the thing, I would rather have 10 parents pissed at me than let 1 kid go and report it. I really feel that strongly about it. And she was pissed at me. It was quite ugly for a while, but I know that I did the right thing, and those kids wound up going into protective custody, and I don't know what happened after that. They're not real good about keeping you informed. All right. Any questions about child maltreatment? Okay. Attention deficit and hyperactivity disorder. Now, Dr. Latassi talked about this in her lecture the other day. What kind of things what did she tell us?
That the description of it sounds like behaviors that everyone has, but that it's about the severity or the extent that they affect the person.
Yeah, very good, very good. Did she talk about treatment plans? Okay, what are your prescribing privileges for ADHD?
Not much.
Like none?
Yeah.
Okay. A lot of times what I'll do for these kids is I'll see them and I'll do the follow-up checks, and we'll talk about that here in a little bit for my doc. So, all right, basically it's a neurodevelopmental problem. It does have 3 different subsets. Did Latassi talk on the subsets? Okay, good. The subsets have come up with the DSM-5 and also with ICD-10. You've got the hyperactivity, impulsive subset. You've got just the predominantly inattentive subset, which is almost any given 12-year-old. And then the combined, okay. Onset, technically, to be appropriately diagnosed according to the DSM-5, it needs to have an onset before 12 years old, although 50% of the kids that are eventually going to have a diagnosis are well recognized by the time they're 4 years old. No surprise here, it's males to females, approximately 2-to-1 predominance, but the inattentive type is more common in females. Okay, so that's a good point. 11% of 4 to 17-year-olds diagnosed with ADHD in 2011, only 6.1% of them were on meds. Does anyone have a guess as to why that might be?
Parents don't want to put
That's
their
right.
kids on them.
That's right, dad's like, it's usually dad, I mean, you know, I'm not trying to be sexist, but it's usually dad says, I got through just fine. You know, I never had any medicine for it. I think Junior's just like I am. Well, yeah, you're right, he's got ADHD just like you do. So, you know, but the thing is once it gets to the point where the kid recognizes that there's an issue, and the kid's teachers, I mean, these kids are just miserable. They're trying their darndest, you know, to succeed in school, or, you know, and they just need that help. I mean, it's like the difference between night and day. In fact, I don't know if Latassi touched on this, but anecdotally, the kid, the 18-month-old that you give Benadryl to, you know, what's Benadryl do to 98% of people? Knocks them out. I can't drive. I take 50 of Benadryl, I can't drive. I mean, seriously, it's worse than like 3 shots of tequila. And that's pretty bad. So, you know, but seriously, you give that 18-month-old a dose of Benadryl and all of a sudden they are bouncing off the walls. Well, anecdotally, I've never seen a study that supports this, but in my years of pediatric practice, that's going to be an ADHD kid. Because what do you do to an ADHD kid? How do you treat an ADHD kid? You
Stimulant.
give them a stimulant, right? And it has a converse effect on them, right? Well, you give them a depressant, a Benadryl, and it has a converse effect on them. And there really is a correlation. One of these days I'll set up a study for that to get with Dr. Benada and see if he can help me figure that out. All right, so these kids have a lot of comorbidities because they're so frustrated with themselves. They have depression, they have ODD, oppositional defiant disorder. Now this is a new one in the DSM-5. This is basically just, you know, kind of that kid that just won't do a darn thing that their parents want them to do. They also have conduct disorders. They have anxiety, and they can also have learning disabilities. The American Academy of Pediatrics uses the DSM-5 criteria for children less than 17 years with greater than 6 inattention criteria and/or greater than 6 hyperactivity and impulsivity criteria. Symptoms must be present before the age of 12 for longer than 6 months, be noticed in more than 2 settings. In other words, it's not just that they're a jerk at daycare. They got, you know, that doesn't sound right. But, you know, it's not that just they act up at daycare, but they also have to have the acting up at home and at school. These kids also need to have a reduced quality of social or scholastic functioning, be excessive for developmental level of child, and are not better explained by or occur with another mental disorder. In other words, it's not something else that you can attribute it to, okay? Like they've got a history they had a history of abuse and now they're acting out, where they had no symptoms before that episode occurred. Does that make sense? Okay. Inattention, careless mistakes on tasks, these kids just don't pay any attention. Difficulty sustaining attention or in organizing tasks, you know, kind of like me when I've got 38 things to do at once, you know, it's kind of hard to focus on something. Does not seem to listen or follow through or finish tasks, avoid tasks that require sustained mental effort, or loses things like cannot ever find their hat or their mittens, forgetful in daily activities. And the hyperactivity, impulsivity criteria for ADHD, they fidget, difficulty remaining seated, runs, climbs excessively or inappropriately. This is the kid that is climbing up on the back of the sofa in the waiting room, running across the top. Difficulty playing quietly. Okay, so I mean, most kids at some point, even if they're rambunctious, outgoing, they will find a toy and go off by themselves and play by themselves for a little bit. These kids don't. Acts as if, quote, driven by a motor or seeming to be always on the go, talks excessively, blurts out answers before the question's complete, has difficulty waiting. This kind of describes my husband. Anyway, has difficulty waiting turns and interrupts others. All right, any questions about any of this so far? Probably a lot of what you got from Dr. Latassi. Children undergoing extreme stress such as a parent's divorce, personal illness, a parental illness, homelessness, abuse, may demonstrate ADHD behavior secondary to stress, but that's not necessarily diagnostic. If diagnostic behaviors are noted in only one setting, explore the stressors within that setting. Okay, so they only act this way at home. Well, what's going on at home? They only act this way at school. Well, what's going on at school? Are they being bullied at school? Is there something else going on? The diagnostic behaviors are more noticeable in tasks that require concentration or boredom tolerance than in free play or office situations. Can this kid sit for 3 hours on a Saturday afternoon and play uninterrupted video games? If he can, that might not be an ADHD hyperactivity. Okay? When you're doing the workup did Dr. Latassi talk about the workup? I don't think Dr. Johnson did much. She didn't mention this really. But when you're doing the workup, you've got to have the school performance. You've got to have input from the teachers. You need to get a physical exam for baseline weight, because if you're going to start them on any medications, we need to be tracking them for normal growth and development. Pay close attention to any kind of soft kind of neuro symptoms like clumsiness or tics or, mixed-handedness, are they sometimes right-handed, sometimes left? I said that exactly the opposite. Sometimes left-handed, sometimes right-handed. And then you also want to do just a hearing and vision check, which should be a part of any new patient physical exam in the pediatric realm. Differential diagnosis for ADHD. This is, it's a big list. It could just be that it's really normal. It's within the normal realm of behavior for a 3-year-old. Okay? It could be they have some kind of language or communication disorder. It could be a hearing or a vision disorder, dysfunctional family situation. Maybe they're just undisciplined, learning disability, are they dyslexic? Autism, are they on the autism spectrum? ODD, Tourette's, Tourette's by itself, or they just have a disorder, a motor tic or a verbal tic. Absence seizures, that would be one you would worry about with the inattentive, obviously not the compulsive, but the inattentive type. Lead poisoning. Does anybody know the story of Flint, Michigan, and lead poisoning? I think, was it Tricia that touched on that? Yeah, that's where my husband grew up, by the way. He's from Flint, he's a Flint boy. But I don't think they had lead poisoning then. Anyway, no, they really didn't. They didn't have it until they switched over and started pulling their water from the Flint River, which if you're from Michigan, you don't even need to fish out of the Flint River. I mean, much less drink that water. Yuck. I know that face, right? Yeah, exactly. That's my face too. Can this be a sequelae of some kind of central nervous system infection or trauma? Okay, did this kid have a traumatic brain injury or something? Medication, are they taking decongestants, antihistamines? Is there inappropriate use of albuterol contributing to this when they really need to be on a maintenance medicine and not jacked up on the albuterol so much? A lot of parents really, I know that somebody talked about the Zoganex with less side effects. Yeah, that's a true thing. I get a lot of parents that will pay, even though their insurance won't cover Zoganex, they'll pay for it because their kid acts better on it than they do on Preventil or ProAir. Theophylline, phenobarbital, sleep disorders, do they have obstructive sleep apnea? Are they, as the fact that they're just so stinking tired all the time, does that make them more, how do you feel when you don't get enough sleep? You a little grumpy the next day, a little touchy? Well, imagine that happening when you're 3 years old and 3 or 4 years old and don't have that control that we're expected to have as adults. All right, so diagnostic tests and interpretations, the behavioral rating scales, Vanderbilt assessment. If somebody wants to, if you're referring your kid out to get one of your patients out to get assessed for ADHD, and somebody wants to spend an hour in the office with them and then diagnose or not diagnose, don't refer to that person ever again. okay? Because they're wasting your time and they're wasting the parents' money. Basically, the Vanderbilt assessment is this huge packet of papers you get. You need feedback from 3 teachers at school. You need feedback from the mom fills out one, the dad fills out one. They don't do it together, okay? And then a lot of times the learning disability, they need to be tested through the schools for any kind of learning disability, okay? For their lab work, you want to get like a lead level. I mean, that should be done at your routine screening, at your well child checks anyway. What is it? I think 18 months, 2 and 4. EEG, if symptoms indicate the absence seizure disorder. Okay, so if you're suspicious that the inattentive type, you might want to throw an EEG into the mix there. Like I said, as far as treatment goes, PAs can't prescribe, but we do follow-up visits. We need a height and a weight gowned, and we need to plot those accurately. A lot of times you can put it into your EHR system, it will automatically plot. Some people still use a paper, and some parents have a copy of the growth chart, and they want you to plot for them so they can kind of keep, I guess they tuck it in their baby. Maybe they've only got 1 kid, I don't know. But they bring it to you and want you to plot on their own piece of paper, and that's fine. For follow-up on when you're ever doing an ADHD recheck, you definitely want to get feedback, grades, what are the parents, what's the parents' feedback? Sometimes you talk to the parents away from the kids, a lot of times you talk to the kid away from the parents. And just the teachers, how are you doing in school? How many times have you had, has your name gone to yellow, if they're elementary school and they use that system, that kind of stuff. You also want to find out if they're taking any kind of drug holidays. A lot of the medications, kids can take drug holidays on weekends, or like if they're out of school all week for Thanksgiving break, they can take drug holidays. What is the purpose of a drug holiday when you're on these kind of medications? Huh?
Pork growth.
Eat. Did I hear somebody say eat? Yeah, you lose the effects of the appetite suppressants, so they get a chance to eat and let their body catch up with that. All right. Right now it's really trendy, diet modifications to control your kids' behavior. The official line from the American Academy of Pediatrics recommends that for a child without a medical, emotional, or environmental etiology of ADHD behaviors, the trial of a preservative-free, food coloring-free diet is a reasonable intervention. So what's the AAP saying here? Sure, give it a try. What the heck, it's not gonna hurt anything. And it's not. Individualized education plan, IEPs, most of those, most schools will have those for a kid diagnosed with ADHD. It takes really good communication between the school and the child's provider. Okay, so the school will send the provider a form, and we'll fill that out and get the kid on an IEP. All right, any questions about any of the ADHD type stuff? So 3 different types of it, males more than females. Yes, Randy?
I was just wondering, is this like, and we didn't really talk about this in pharmacology either, is there a difference between ADHD and ADD? Or is it just like a part of that?
ADD really it's the DSM-5 reclassified it, so ADD isn't a thing. ADD would be the ADHD inattentive. Okay, so I mean that's the new classification for it. Does that make sense? Any other questions? Anybody? Okay. All right. Let's go to eating and feeding disorders. Okay. Age-related, definitely. Infants are sometimes overfeeding. Toddlers are growth-dependent. School-aged are willful feeders, and adolescents we worry about body image feeding issues. Dr. Johnson said something about the toddler slump. Yeah, the toddler slump. You spend most of your time at a well child check talking about your kids' food, their kids' food. parents are just really worried about this. Am I adequately, I'm giving them the nutrition they need, they don't understand. One of the things that I always talk about at every visit, by 9 months, they need meat in their diet, okay? If the parents are vegetarians or opposed to feeding their child animal products, then we need to find out how the parent themselves gets their protein in their diet, and make sure that that they're doing that for their child also. Around 12 months, the kids will eat them out of house and home. They're ready for cheeseburgers and french fries. Around 15 months, you think that your child has not consumed enough calories to sustain life that day. You know, and I always tell the parents at my visits, please don't do anything differently for your kid as far as what keep offering them a healthy balance of food. You've got that plate, just put like 5 carrots on it, 4 peas, just scarce, make it look scarce. Because a kid that doesn't have much appetite anyway, because they're not in a real heavy growth spurt, they're just not gonna have much appetite. They don't have much appetite anyway, and they look at that plate full of food and they think, oh, I can't eat that, forget it, and they won't even try and flip it off. They'll flip it off the tray for the dog. But if you give them just a few things and make things look scarce, then it can be good. Continue to offer a variety of foods. If you know, this is what I say to parents, if you know that your kid will always eat chopped ham and peaches, don't just feed them chopped ham and peaches because you know they'll eat them. Keep offering a variety, maybe give them a little, maybe just a little, but keep offering everything else and eventually they will come through it. If you cater to the kids' preferences at 15 to 18 months old, that's how you get that 5-year-old that won't eat anything but chicken nuggets and french fries. And nobody wants that for their kid, right? So that's the toddler diet slump. That is a true thing. If they're not in a growth spurt, they're not going to eat. If they're in a growth spurt, you're going to think they're going to eat as much as you do. And you're thinking, where are they putting all that? Okay. School-aged and willful, a lot of times you've turned it into a battle. I mean, there's very little this kid can control, but they'll try to do that, I'm not eating that, you can't make me, so why make it a thing? Why make it a stressful thing? That's what I always tell parents. Another thing, when their kids are in a toddler slump, and a toddler eating slump, so many kids today, and it's frustrating, but they walk around with a sippy cup and then that cup of the goldfish all day long. And then the parents are like, why aren't they eating their lunch? Well, because they've eaten for every 10 minutes since breakfast. So take away the cup, take away the snacks. If you're gonna feed them snacks, make their snacks something healthy. Like Dr. Johnson said, so much of the stuff aimed at kids for snacks is just crud. I mean, it's not worth eating, okay? So if you take that cup away 45 minutes before a mealtime and then don't offer them the cup until, they're halfway done with their plate, you'll see a big difference, All right, anorexia nervosa, DSM-5 criteria for diagnosis. Restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as a weight that is less than minimally normal, or for children and adolescents, less than minimally expected. So this is, remember Dr. Johnson talking about the 2 lines on the growth chart? This is the 13-year-old that's gone through puberty, and now, while they're still developing, they've dropped from the 50th percentile to the 5th percentile, okay? Intense fear of gaining weight or becoming fat or persistent behavior that interferes with weight gain, even though they're already at a significantly low weight, okay? Disturbance in the way in which one's body weight or shape is experienced, undue influence on body weight or shape, on self-evaluation, or persistent lack of recognition of the seriousness of current low body weight. This affects approximately 0.5% of girls in the United States, so it's not real hugely common, but it's out there. And 10% of all anorexia nervosa patients are males. So don't let that, don't let that completely leave your brain when you've got a male doing the same thing. Subclinical or atypical anorexia, they're just super diet conscious, afraid to gain weight. It's getting a little bit better as our fashion industry has kind of tried to get away from the Twiggy type. Does anybody know what I'm talking about? The Twiggy type models. So it's getting a little bit better, but it's got a long ways to go. We need to find out their exercise history, their menstrual history. Why the menstrual history?
Because it causes amenorrhea.
Yeah, they'll have amenorrhea once they get to a certain percentage of body fat. We need a complete physical. The Russell sign, that's the callousing of the finger from making themselves throw up, from purging. That's a Russell sign. Their body weight is less than 85% of expected. Okay, so basically this is not an easy fix. There's nothing to prescribe for this. I mean, it's going to be a multidisciplinary team approach. It often involves inpatient treatment. They need medical treatment, psychological treatment, nutrition. So when they fail that outpatient approach, that's when you consider the inpatient. All right, any questions about the eating disorder? Okay, depression, pediatric and adolescent depression, yes, it does happen. It happens more frequently than you might realize. General term that includes, just to say depression in an adolescent, it includes everything from major depressive disorder to dysthymic disorder to depression associated with bipolar disorder or adjustment disorder with a depressed mood, okay? Syndrome of persistent sadness or irritability associated with a variety of symptoms resulting in functional impairment in the following. They have interpersonal impairment with their family and friends, with those relationships. They have some impairment of their health, somatic complaints, or unhealthy habits. This is the Monday morning tummy ache, doesn't want to go to school. Work or school task completion, their grades, it interferes with that. Safety, high-risk behaviors including attempted suicides. Okay. All right, any questions about any of that? Risk factors for pediatric and adolescent depression are pretty much the risk factors for almost all the other disorders that I'm discussing this morning. Family history of depression, bipolar disorder, suicidal behavior in a first-degree relative. So a parent that attempted suicide in their teens is much more likely to have kids that will follow in the same steps, even though that happened long before that kid was born. Prior depressive episodes, personal history of anxiety disorders, ADHD, learning disabilities, and early losses. Early losses is mom died, dad died, the grandparent, custodial grandparent, something along those lines. Family dysfunction or caregiver dysfunction in conflict with the child. Negative style of interpreting events and coping with stress. What do they see their parents do when they get stressed out at work? They come home and kick the dog, that kind of thing. Substance abuse, a history of trauma, bullying, the patient themselves a victim of abuse, or chronic illness, including obesity. I mean, that's considered a chronic illness. 40 to 70% of children and adolescents with depression have comorbid psychiatric disorders, such as anxiety disorders, somatization disorders, disruptive behaviors, and ADHD, ODD, conduct disorders, eating disorders, substance abuse, physical or sexual abuse. All right. Screening for pediatric and adolescent depression, U.S. Preventative Services Task Force recommends routine screening of adolescents for depression in clinical settings that can ensure accurate diagnosis and appropriate management and follow-up, universal surveillance for younger children. We have, at Dr. Johnson's office, she's got a screening tool that we do at every well child check, and a lot of times we'll pull it out and do it at just a situation where we just kind of want to get an idea. And most of the time, kids will be on it. They are just, most of the time, kids in this situation are just really, I mean, if somebody wants to know, they want to talk about it. They want to let somebody know, so they will very rarely skew the results of these self-screening tools, especially when they know that their parents won't see them. They won't see the results of these self-screening tools. If the screening tool identifies depression, diagnosis should be established through formal assessment and risk for suicidal behavior assessed. I had a kid, Dr. Johnson was just out on back surgery, and I covered for her as much as I could. Dr. McNeil's awesome, let me slip out and cover, but she finally found a doc that's a pediatrician, semi-retired, but not real comfortable with adolescent behavior stuff. So they had a couple of kids that I made a point that came and saw me just at like 4:30 or something like that, and I'd let the staff go home and and see these kids. But one of these things is, when you've gotta, I mean, it sounds silly, it sounds trite, it sounds completely ridiculous, but you look a kid in the eye and you say, here's my cell phone number. If you feel like harming yourself, will you call me first, please? And they will. These kids, they just want somebody to hear them. And their parents, they don't often understand that their kid is hurting that bad. So for somebody just to reach out to them, and for me to offer that kid my cell phone number, I started her on, I started her on a little bit of an SSRI, a low dose, and stepped it up after a couple of weeks. And the next time I followed up with that kid 6 weeks later, so I haven't heard from you, you didn't call my cell phone. And she goes, I didn't even have those thoughts run through my brain. I mean, that was just, to me, that just made it all worthwhile, just that one kid, All right, so screening tools include the Patient Health Questionnaire for Adolescents. It's got a 70, here's more numbers I don't care about. It's a pretty good test, is basically what it says. The Beck Depression Inventory Primary Care, which got pretty good numbers also. Strengths and Difficulties Questionnaire, and additional tools, the Kuchar Adolescent Depression Scale, Reynolds. I don't expect you to know all this. Just know that if you wind up in a PEDS office, you can get most of these tools through the American Academy of Pediatrics. Or some of them are even free. You don't even have to be a member of the AAP. So mild depression, which is not what that kid described to me. That kid had me scared. I worried about that kid. I prayed for that kid. I worried about that kid a lot. Mild depression, you want to start with supportive management. Sometimes I've seen Dr. Johnson see these kids with mild depression back every 2 weeks. They're the last appointment of the day. The staff knows they can go ahead and leave at 5 if Dr. J is still in there, that kind of thing. So if they just see you weekly or bi-weekly, a lot of times just the fact that somebody's listening to that kid. We often ask kids to journal, do something to focus yourself. A lot of times you write stuff down that helps. Does anybody in here journal? Well, heck no, you ain't got time for that, right? But no, it helps, doesn't it? Does it help you think about the way, it does, it helps you with introspection. And some of us have more problems with introspection than others. But anyway, but if the depression worsens or doesn't improve with that intense supportive management, then that's when you think about additional intervention. Moderate depression, adolescent psychosocial and medical interventions are equally effective with slightly increased benefit with the combination of the two. So I'm not just going to hand you a prescription of, Celexa and see you back in 6 months. I'm gonna see you every 3 weeks, every 4 weeks, I'm gonna see you on a regular basis to ensure that that's really working, and that, that has the best treatment there. Select, like I said, SSRIs are the first line choice. What's the one thing that you really worry about though when you start a kid on an SSRI? It actually increases the risk of suicide, okay? And my theory behind that is because they've been in a funk for so long, they had no motivation to do anything. You get them a little bit out of that funk and suddenly they got the motivation to do something. So that's where you want to really have that close follow-up, and that's where you want them to have a suicide, an anti-suicide agreement with you, okay? That's pretty much what I just said. Premenstrual dysphoric disorder, a lot of times, I mean, I tell, when I do a well-child check on an adolescent female, I say, how are your cycles? And they look at you and you say, your periods, how are your periods? You have a period tracker in your phone, and they're like, oh yeah, everybody's got an app, what the heck? I just had a red pen and a calendar. But anyway, so everybody's got an app, they keep track of it. And I always say, are you okay with your periods? And they're like, no, I hate them. Yes, I know, but can the attendance secretary plot your menstrual cycle? Because if that's what's happening, that's not appropriate. Okay, so I give them the, we're women, we're tough, we bleed, we get up, we go on, that's why it happens to us. So, and then sometimes that's all it takes. But if it truly is, if they truly cannot function 2 days out of the month, then that's when you might consider an SSRI for those people, okay? A lot of times you can pre-treat premenstrual dysphoric disorder that's associated with heavy cramping and a lot of pain and bloating. 3 days before they're expected to start their cycles, put naproxen 500 POBID for just 3 days before they start, and then PRN afterwards. And a lot of times that'll take care of it. That, along with an SSRI, can change a teenager's life. All right, so any questions about depression? Are you guys ready? I got about, what do I got? I got about, I don't know, 30 slides left. You want to break now, or you want to just, anybody need a little break, or you can keep going about another 10, 15 slides? Or we can just keep going all together. I don't care, I'm easy going. All right, anxiety, if you guys change your mind, just speak up. Anxiety, separation anxiety disorder, this is developmentally inappropriate versus developmentally appropriate, okay? It's normal for kids to not want to see mom go by. If you've got a kid that completely doesn't give a flip whether mom's there or not, well then we might be dealing with something else, maybe an attachment disorder or something along those lines. But, we shouldn't have a kid that, you'll know it when you see it, right? Environmental and genetic precursors, temperament, behavioral inhibition in which a child tends to approach unfamiliar situations with distress, restraint, and avoidance has been shown to be associated with developmental anxiety disorders. So this is a kid that never wants to do anything new. Okay, they're stressed out by every situation. You sign them up for T-ball, they won't get out of the car when they get to the ball field. Okay, they're they're a prime candidate for a separation anxiety disorder. Early development of stranger anxiety. What's the most typical stranger anxiety age of infancy? Where does it usually rear its head? 9 months. 9 months. That kid that loved you at 2 months, 4 months, 6 month well-child check will not look at you at the 9-month visit. They hate your guts. And then by 12 months, they're fine again. But around 8 to 9 months, if they develop that stranger anxiety at 5 months, then there might be something more going on. Insecure attachment between the parent and the child. They don't have a good attachment, so the child clings even further. The child, even though they're kind of new at this thing, they know that there's something missing, so they can have separation anxiety also. Increased parental anxiety. The helicopter parents can create a kid with separation anxiety disorder. Does everybody know what I mean by helicopter parents? Okay. Parenting style of being excessively controlling and overprotective. So that's the mom that's at the Chick-fil-A playground, don't, that kid, that mom? Yeah, drives me crazy. Exposure to negative life events or stressors. Well, that's kind of self-explanatory. They wound up homeless, they wound up, something like that, that can be a precursor for that. A genetic predisposition with family history of anxiety or depression. All right, maladaptive, interfering with normal functioning or becomes overly frequent, severe, and persistent. Basically, separation anxiety, it's a recurrent excessive distress when separation from home or major attachment of figures occurs or is even anticipated. So this kid freaks out when mom overhears mom saying to dad, I'm gonna go, and the kid loses it, okay? Persistent and excessive worrying about losing or about possible harm befalling major attachment figures. So this is the 6-year-old that's obsessed with dad dying in a plane wreck. Even though dad works at, Dairy Queen and doesn't drive planes but once every 30 years. I'm making this stuff up. Persistent and excessive worry that an untoward event will lead to separation from a major attachment figure, like getting lost or being kidnapped, okay? There's a fine line. You need to teach, you gotta teach your kids about stranger danger and being aware of what a stranger is without making them freak out about it, okay? Because if the parent has been overly, has been emphasizing that point too much for too long, then they get a kid that just kind of freaks out about it. Does that make sense? Persistent reluctance or refusal to go to school or elsewhere because of fear or separation. Persistently and excessively fearful or reluctant to be alone or without major attachment figures at home or without significant adults in other settings. So this is the kid that will never take the toy to their bedroom and play by themselves. All right. Boy, there's a lot of this stuff. Basically, they don't want to go to sleep without the parent. A lot of times I've seen kids that mom said, well, he has to have his hand on my cheek. Well, that's kind of a pain in the rear. How's your quality of life sucks? Persistent nightmares involving themes of separation. Repeated complaints of physical symptoms. Every time mom leaves, the kid gets sick. Grandma, I got a headache, I got a stomach ache. Even when they're leaving them with someone good, like grandma, right? Okay. Duration of disturbance is at least 4 weeks. So this isn't just an intermittent thing. This is a persistent, consistent, lasting at least a month. Onset before 18 years old. I hope you don't get separation anxiety when you're 20, guys. Really, seriously, that would be scary. I don't even know where that one would fit in. Disturbance causes clinically significant distress or impairment in social, academic, or other important areas. Okay, in other words, your kid's freaking out at daycare, you gotta leave. That's kind of what this refers to. It's not the 4-year-old with the job, it's the parent. Okay. All right, so you're trying to assess this. You're wanting to get a feel for this in a family situation. You ask if sleep is impacted. Ask the kid about nightmares. What do you dream about? A child with separation anxiety disorder has nightmares about separation, death, kidnapping, or serious accident. Ask if school attendance is impacted. This kid's so anxious that they miss school once every 2 weeks because they just can't bring themselves to leave mom that day. Avoidance behaviors such as procrastination during the morning routine. Who hasn't seen that, right? Refusing to leave the side of a parent is common. School refusal has been reported to occur in approximately 75% of kids with SAD will miss a day of school for no physical reason. Ask about duration, how long has it been going on? Transient separation fears are common, especially when a kid has a they've crossed a developmental milestone and they've gained a little bit of independence, then oftentimes they'll exhibit this type of behavior very temporarily. It's like the, 3 steps forward, 1 step back kind of thing, So it's, transient is okay, that's expected. And see if there's any particular stressors that, like, are the parents separated? Parents are separated, anticipating divorce, then the kid can form form a separation anxiety disorder with the parent that still has custody of them. Does that make sense? All right, so the physical exam, yeah, no, nothing, yeah, kid looks perfectly normal. Diagnostic tests, nada, nothing. And there's like the other ones, there's a ton of scales, that you can find through the American Academy of Pediatrics and things like that if you really feel like you need to actually quantify something. That's the nice thing about the scales is you can use it and have the parent quantify the results, and then in 9 months have the parent retake it, and a lot of times you'll see the improvement. So that is a nice benefit of using some of these standardized scales. All right, so the differential diagnosis for separation anxiety disorder is just obviously in the differential you're going to have generalized anxiety disorder, but when you've got a generalized anxiety disorder, a lot of times they have concern over something else. They're actually concerned about something else, not just the separation. Maybe their school performance, maybe performance in sports at school, something along those lines, okay? They can also just have some social anxiety, avoiding social situations. Some kids don't like to eat in public. This isn't just the Friday night dance of middle school, which should be really outlawed and just all together. Don't you think? I mean, come on. Those things were stressful. I don't care if you were the best, well-developed kid, most well-rounded kid on campus. Those things were stressful for everybody. All right, or they can be having specific phobias. Maybe they have a phobia, agoraphobia. They don't want to be out in public, They might not recognize that, they might not be able to put a name on that specific phobia, but it's up to you to kind of tease it out and see if that's more along the lines of what you think is happening. So how do we treat this? Well, caregiver education. Oh, man. Okay, yeah, I'm going to get on my soapbox again for a minute. Parents that refuse to say goodbye to their child drive me insane. All you're doing is you're teaching that kid that you can't be trusted, right? You go up to your 2-year-old and say, okay, Dad and I are going to the movie and you're going to stay with Aunt Robin for, 3 hours and then we'll be back. You might be asleep when we get back, but we'll wake you up and take you home, okay? Bye, and then walk out the door, okay? But, I mean, if you're the sneaky parent and you're saying, okay, Aunt Robin, take her in the other room and get her some ice cream and we'll slip out. If you're ever asked to be in that situation, don't play along with that insane parent. Don't do it. Okay? Seriously. Because that kid comes around the corner and is like, wait, Mom was just here, where the heck did they go? And then they're ticked off every time they cannot lay eyes on you. They think you've snuck out for another 3 or 4 hours. Does that make sense? Yeah. And the ones that just kind of, ease out the door. No, man, just do it. Just do it. Cold turkey. I'm leaving. Bye. Right? And the most important thing is don't let that kid know that, because no parent wants to have a kid crying, when they leave them in the church nursery. No parent wants to be down the hall still hearing their kid scream. Don't let them see that upsets you, okay? Because that just increases their anxiety. And then when you see him again, you don't have to bring him presents. You've been gone for 3 weeks, okay? Just, hi, boy, that was fun. Did you have fun with that, Robin? How much ice cream did you eat? Yep, I bet a bunch. And that kind of stuff. It doesn't have to be a big thing. They don't get, a toy just because they, got left at Aunt Robin's. You know what I mean? She's not that bad of a person, really. Right? Okay. If they're really having extreme difficulties, if the kids are really having problems, you gotta counsel these parents, because this can, man, oh man, you're the mom with a kid like this, you just wind up so depressed and anxious yourself, and you feel like, I'm such a failure. You see other kids at the park that run off and go play on the toys, and yours is there like pumping your leg or something. You're just like, go play. So you start with small separations, okay? So really encourage the parents. You can use incentives and positive reinforcements like stickers. I'm a big fan of sticker charts. Anything you're trying to help a kid learn how to do, positive reinforcement with a sticker chart is amazing, okay? So, we're gonna go to daycare. You go to daycare all week long. For every day that you don't throw a fit, when I leave in the morning, we're gonna come home and put a sticker on your chart. When you can get a sticker on 3 days of that week, you're talking to your 3-4-year-old, right? When you get a sticker on 3 days of that week, we're gonna do something special on the weekend. We're gonna spend an extra half hour at the park. Okay, it doesn't have to involve money, doesn't have to involve candy, anything like that. Nothing that you need to purchase for this kid. You can even, you got 30 minutes in your budget for the park on a Saturday afternoon. After 15 minutes, you say, okay, here's the bonus time right now. We're doing the bonus time, otherwise we would be leaving right now. But go play, you have another 15 minutes, because you're so good, and you got 3 stickers this week. It's simple, guys, it's simple. You can do something as simple as an extra story at bedtime. Man, that one goes a long way with those 4-year-olds. Tonight you get to choose 3 books, because you got 3 stickers on your chart this week. You can do the same principle with potty training. You can do the same principle with kids that sneak into your bed at night. Drives me crazy. Every morning you wake up in your own bed, there's a sticker on your chart. Okay, so this is something, once a parent develops this technique, that's good. And they can use it. You'll be amazed at what they can apply it to. They'll get creative with it. All right. Of course, once you get to be 12, an extra story at bedtime doesn't carry the weight it does. So you gotta come up with something. You gotta make it something good, something rewarding for that age-appropriate kid. And it might be, oh my God, my grandson, Morrison, the most adorable child ever, mainly because he looks just like his dad. Anyway, he loves his soft pants, like sweatpants. And soft pants. And his mom, I love this about Jackie, she took away his soft pants from him. You don't get your soft pants back, you gotta earn those soft pants back. That was hilarious, and it was all over. He's a little artist. I got his easel and color, and he just, he got sloppy, and he wouldn't pick up his stuff anymore, and the dog would chew up something. That was what it was. He lost his soft pants. He had to earn his soft pants back by putting away his art supplies for 3 days in a row. Brilliant. I loved it. All right. So where else are we going here? I got sidetracked. So basically, it lasts 6 months or more to be able to diagnose this. It's not intermittent, it's persistent. It's not attributable to some other psychological effect of abuse or a medical condition or something like that. The kid that's been the kid's been diagnosed with something horrible. Oh, don't slap this on them too. No, that's just normal in that situation. If it's performance only, are they just fearful of being expected to talk to somebody outside of their comfort zone, something along those lines? Okay. All right, 7% of children suffer from social anxiety disorder. The prevalence is somewhat higher in girls than in boys. Once again, not real surprising, I don't think anyway. Okay, social anxiety, the diagnosis is history dependent. You're not gonna, we might see it demonstrated in your office, but it's basically history dependent. So you're diagnosed, how to diagnose this, you got to gather data through separate interviews with the child and the parents. Okay, this is another situation where you're gonna split the folks up. Current symptoms should be elicited with attention to severity, duration, and level of functional impairment. Did they get the role of, third snowman in the school play, and they actually made it to the play, but then they couldn't come out from behind the curtain? Something like that, but more persistent. That would just be like a big manifestation that everyone would remember. Core symptoms of marked anxiety in social situations, fear and negative scrutiny by others and avoidance of these situations should also be present to make this diagnosis. Distress can be manifested by physical symptoms such as blushing, palpitations, or even physically trembling. Kind of like I do before I have to get up and lecture in front of you guys, right? GI upset, tummy ache. Younger children may exhibit periods of selective mutism in social situations while having the ability to talk freely at home. So this is